Hello, everyone. My name is Eileen Sullivan Marks, and I have the privilege to be the Dean of the NYU Rory Myers College of Nursing. And I am simply thrilled today to welcome you, so many of you from around the world, and our colleagues that we've worked together with for more than a decade now with the Rwanda Ministry of Health to bring health and human resources for nursing and nursing education in Rwanda. And so today our webinar will be presenting the impact of the Human Resources for Health program on nursing clinical practice and health systems development. And I am thrilled to have this as our second in our new series of Dean's Global Health Lectures from NYU College of Nursing. I know that some of our colleagues who've been involved in this nursing and medical project throughout the United States and the world are with us today, and I welcome you. And I really hope that we will have time for some wonderful interaction with this great panel. I'm going to first introduce our moderator, Professor Robin Klar. Robin is a clinical associate professor at NYU Rory Myers College of Nursing. She has been working in the area of global health throughout her career with her interest in community health, both locally and globally. After she received a doctorate of nursing science from Yale University, she went on to do a postdoc at Case Western University, in which she participated in global health programs in Papua New Guinea. Here at NYU, she has used her expertise to influence the built environment on population health outcomes and care delivery. And she has been expanding our work in projects in low and middle income countries, particularly in West and East Africa. She looks at capacity building projects that support a robust south to south shift, furthering their sustainability. She recently received an award for her work from the United Nations in 2019 for a Global Impact Award. Thank you, Robin, for moderating this session, and thank you to all of our panelists today. I turn it to you now, Dr. Klar.
Thank you, Dean Sullivan Marks. We are very excited for the entire concept of your global lecture series, and very thrilled for this second global lecture series today on HRH Rwanda and its impact on nursing and midwifery leadership and the health systems in Rwanda. I will share with you a brief history and introduction to Rwanda and the HRH program, and then we will move forward with our panelists. A brief map of Rwanda, just to bring us that geographic context. Next slide. So Rwanda is a post-conflict country of 13 million people. And Rwanda has been building their country since the conflicts ended, and they've been very deliberate and very focused on this. Their critical industries right now are service, construction, and agriculture. And Rwanda is the 38th of 190 economies that the World Bank looks at as an ease of doing business index. And this is critical. This has really launched Rwanda as a very engaged and moving partner in Central Africa. Next slide. They have escalated their economy. As most economies during this pandemic, we have all seen a de-escalation in our profits. But Rwanda is unique in that it has an extraordinary number of parliamentarians who are women. And when we look at nursing midwifery as primarily a profession of women, this is very exciting. They are continuing to work forward to build up their country with some recent awards for both digital acceleration and also for roadway infrastructure in Rwanda. Next slide. Part of the building up in Rwanda has been the escalation of education. Conflict will do that. It closes down schools and economies. So Rwanda has been very diligent in expanding their education. Initially, it really looked at quantity, but they realized very quickly that quality was the really important initiative. So they've moved forward, and the whole rest of our HRH Rwanda presentation today will really look at the quality of education and nursing and midwifery practice that is ongoing in Rwanda. Next slide. So the Human Resources for Health project was launched in August 2012. It's an enormous partnership, probably the largest and deepest partnership with capacity building for health services and health clinicians in the globe. It's had many contributors as funders from the US government, PEPFAR, USAID, and the CDC, and also the Global Fund. And the targets really were looking at the shortage of the skilled healthcare workers, improving that quality of education, and really looking at infrastructure. Next slide. But today we really want to focus on HRH Rwanda nursing and midwifery. And the critical actor in Rwanda is the Rwandan colleges and universities. Initially, we started out with the HRH Rwanda project looking at the Kigali Health Institute that is now merged, and it is the College of Medicine and Health Sciences with the School of Nursing and Midwifery embedded. The college also works with multiple clinical partners in Rwanda, and you will hear in our presentations today the amazing networks and clinical partnerships that have been developed as a result of these 8 new master specialty programs. We've had many academic partners from the United States working in Rwanda for this project. Their dates are here. And to date, NYU Myers and the University of Illinois at Chicago are the remaining partners that have visiting faculty on the ground in Rwanda. Next slide. So capacity building framework. We are really focused on recruitment and hiring of visiting faculty. Initially, HRH Rwanda focused on clinical faculty, but very soon into the project, from 2012 to 2014, Dean Donatilla at the University of Rwanda realized that to do this further elevation of capacity in Rwanda, we needed master's programs to increase the capacity and the education of current Rwandan School of Nursing and Midwifery faculty and creating future new Rwandan faculty. So we assessed the practices, quality improvements were established. Dean Donatilla moved forward with all visiting faculty and visiting institutions to hire visiting faculty. And today we will hear from 3 of those specialty programs. No disrespect to the other programs, but we had to figure where the stop was. So today we'll be hearing about critical care, nephrology, and oncology. And I just really want to give a shout out to Rwanda and the Ministry of Health. They have since created the HRH Secretariat, which has more capacity within Rwanda to move forward on the National Strategy for Health Professions Development 2020 to 2030. Next slide. So today we're talking about capacity building, both at the individual level, within clinical specialties, and health systems overall. Today we'll learn more about each of these capacity building strategies in critical care with Dr. Busi Bengu, in nephrology with Dr. Lakshmi Rajeswaran, and in oncology with Ruth Sego, soon to be Dr. Ruth Sego, and Dr. Margaret Fitch. Next slide. So today, at this moment, I would like to introduce everyone here to Dr. Busi Bengu. She is a former NYU Myers nurse educator, visiting faculty with the Critical Care and Trauma Masters of Nursing track at the University of Rwanda School of Nursing and Midwifery. She's an honorary associate professor at the University of KwaZulu-Natal, a professional advisor at the accreditation section of the South African School of Nursing Council. Dr. Bengu has advised 10 countries across Africa and the Middle East on nursing curricula. She's a member of the Technical Committee of Council for Health Service Accreditation of Southern Africa. Dr. Bengu is a prolific author. She has served as head of School of Nursing at the University of KwaZulu-Natal. the director of the WHO Collaborating Center at the University of KwaZulu-Natal, executive member in the global network of the WHO Afro-Region Collaborating Center, and finally, the chairperson of the 15th Council of the South African Nursing Council. Welcome, Dr. Bengu.
Thank you, Dr. Clark, for the introduction, and greetings to my home country, second home country, which is Rwanda. Critical care was a track that I took responsibilities with a number of twins as they came and went. I taught 2 tracks which completed. The first cohort completed, 16 students completed, and 15 out of 16 students completed in 2017. 12 students plus 1 graduated in 2019. Next slide, please. Next slide, please. It was a pleasure to successfully implement an innovative curriculum, which is a concept-based curriculum. And this curriculum was a hybrid because not the whole curriculum was concept-based, but we used this approach for clinical specializations. And the reasons for adopting this curriculum were to apply concepts in multiple contexts, connections with past learning as RNs, registered nurses that have had the experience in the track, sharing concepts among specialties, and saving on limited resources, even space, because we did not have many classrooms. We had to share 1 classroom. And the concept base was exactly what we needed for that type of space, where we shared the concepts like perfusion, oxygenation, ventilation, intracranial regulation, or intracranial pressure regulation, and the diseases from the various specialties became exemplars for these diseases. Next slide, please. Next slide, please. Another method that we used was a symposium, which we used to teach the content of special populations. The class of 2016 to 2017 organized this symposium sponsored by SAM, which is a training support access model. This model was targeting midwifery. However, because special populations included a pregnant woman in ICU and a pediatric patient in ICU, the symposium fell within the scope of that support. Hence, we managed to even buy valve sheds, as you can see us in the picture. 72 participants from all referral hospitals in the country with intensive care units attended. That included heads of anesthesia who presented a very interactive talk on post-anesthesia patient in ICU, directors of tertiary hospitals, ICU unit managers, including neonatal ICU, pediatric ICU, and maternity specialist ICU. Representatives from the education institutions, including campuses and the University of Rwanda, including students from other trades. And comments on this symposium was phenomenal, and a lot of networking bore fruit later on. And the comments were very phenomenal, and we used this network in our future. The next slide. We extended the exposure of students in terms of teaching methodology to conferences, and there were quite a number of conferences that occurred in the country. The first International Rwanda Conference, where the students were presented about 5 papers. The African Conference in Emergency Medicine, where they attended. Unfortunately, this one we got the announcement late, and so there were no presentations from the track. First annual Rwanda Trauma Symposium, we caught this one at the tail, and so only the faculty presented, but all the students attended. The African Federation of Intensive and Critical Care Medicine in Rwanda all students attended, and they got to have a lot of networking with one of the faculty who was my twin, appointed or selected to participate in a network of this Confederation of Intensive Care and Critical Care. And the African Confederation of Intensive and Critical Care Medicine also occurred in Uganda. 3 of the students attended and presented papers for which they had presented abstracts which were accepted. They were sponsored by myself, unfortunately, but successfully networked. They even had connection with intensive care nurses in Cameroon, Kenya, and other countries. Next slide, please. Next slide, please. We had a lot of collaborations, and those collaborations were both with clinical staff as medical and nursing staff. For instance, the anesthesiologists participated in teaching theory, some theory and clinical, including the basic life support and the ACLS, advanced life support. The clinical nurses in ICUs were also appointed as adjunct lecturers in adjunct lecturer positions, and 5 are already from the 3 tertiary hospitals, and they share the platform for teaching both in the university and in the clinical settings. As these students also participate together, in fact, both the staff and students participate together in preparations of presentations in this conference. As you can see, some of the students in the presentations. We also shared even seminar rooms. For instance, the King Faisal Hospital had a seminar room which we used both for presentations or lectures, or especially lectures that were shared with anesthesiologists and emergency doctors, and also for case presentations for clinical examinations. Next slide, please. Collaborations did not end there. They continued in tertiary hospitals, both public and private, and this time with interprofessional research. And there were 2 projects that we started and wrote proposals, successful, well, I wouldn't say successful proposals, but we wrote quite intensive proposals. One was a multi-research on nutritional support in ICU, having had the patients or the relatives having to bring diet, a liquid diet for their patients in ICU for nasogastric feeding intermittently. Due to concern about the safety of this nutrition or diet, we then formed a team or a multidisciplinary team of an anesthetist, a surgeon, a nutritionist, a food scientist, and then a nursing, which was myself and my former students who were then twins in the critical care track. Then we also had a multiple research collaboration aiming to apply for funding on evaluation of current emergency and trauma care practices in rural Rwanda, implications for change. And the change was actually to determine how much of early critical care is provided in the rural areas or peripheral hospitals, whereby we would then look at introduction of early critical care, which would include teaching and empowering these nurses in the rural areas on more intensive monitoring or triaging and monitoring of patients, so that they are able to refer them on time while they are still having reversible conditions and no futile admission to ICU. Unfortunately, these projects did not get funding, and I left the country while they were still in the proposal form, and I hope they were pursued after I left the country. Next slide, please. Next slide, please. Thank you. Another interesting collaboration was with the visiting heart teams from Boston and Belgium for surgery, predominantly corrective surgery for congenital heart defects. This collaboration helped with exposure of students for heart surgery, which heart surgery experience, which did not exist in the country, but they were visiting teams intermittently. The most important and special collaboration was with the Team Heart from Boston, who began to engage students in pre-screening for heart surgery. And these students were specifically selected from the university. Students were also engaged in post-heart surgical care, as these teams would leave the country after the surgery with a few cardiologists to monitor and manage complications of this patient. And I have recently heard that this team is introducing cardiac surgical nursing program in preparation for open heart surgery in Rwanda. Next slide, please. Well, we started the program with the aim of being utilized as critical care nurses. Therefore, we had to market the critical care nursing track. And this we did firstly by making sure collaborations are strengthened with the clinical staff. Secondly, we wrote a concept paper with the critical care students. And this was to market or sell the competencies of the specialized critical care nurses, to just indicate to them that we are ready to be utilized in the critical care settings, which were included emergency, critical care settings, including a recovery room. We also attached to this concept paper a scope of practice that was part of the assignments of students to present to the Nursing Council. I'll talk later about it. Another concept paper was also written to establish a critical care discussion group. 2 meetings towards the establishment of this group had been held when I left. And this was based on the belief that unity is strength, to lobby for the track to be utilized in the country. One physician even proposed to be invited to this group if successfully formed, because there was none for critical care, medical critical care people. Next slide, please. To promote absorption of students further, each class in core module, the core module called Transformation of Nursing, developed a scope of practice to present to the Nursing Council to start regulating the specialization, as we all know that for recognition, some of these must be presented. All students are working in ICU or emergency setting. One is in charge of multidisciplinary ICU. Another has been put in charge of cath lab, which she commissioned, and one in the military is engaged as trainer for BLS and ACLS, and many faculty teach. Next slide, please. Next slide, please. For best practice, we have initiated the use of the laboratory for simulation laboratory for clinical examinations, OSCE, using high fidelity models, mechanical ventilator, and cardiac monitors. And that was a successful OSCE, which I did with my faculty, and I can see they're continuing, as you can see them on the slide, wearing masks, they're continuing to use the laboratory. Online learning started with critical care track even before the era of COVID-19, with faculty not being full-time. That is myself not being full-time. I was doing most of the research projects. Actually, all the research projects were supervised online, including some class projects. Next slide, please. Community engagement. We initiated a motorbike project to encourage safety. We had noticed that policies and rules were in place, and they took, so we decided to take an angle of scaring them. And so we developed a brochure where we shared the extent of motorbike accidents and consequences thereof. But unfortunately, the logistics were not in our favor. The brochures are still available, but I hope the track has continued with the project. Next slide, please. Next slide. Next slide, please. The challenges, I'm seeing 2 slides in one, okay. the threat of pandemics, the threat of Ebola, which never reached Rwanda, fortunately, was existing. And now COVID-19, which is real, but academic life has gone on online, fortunately. And I congratulate Rwanda for that. Perhaps the twinning system could be strengthened with some incentive for the local twins. Funding for publications could be included in the application for funding, because I struggled to get the publications through. For instance, in the first cohort, only 6 of the 16 projects were published, and the others, much as the lip service is paid on the low-income countries being exempted from payment or publication payments, people would say, we'll give you a discount, but still you have to pay $427, which is very expensive for us. Internship abroad for the few deserving students could be extended to other tracks. Next slide, please. Next slide, please. Sustainability of the critical care nursing tract. The visiting faculty, that is me, left Rwanda in 2019. There has not been any visiting, well, there has been one that left because of COVID. So far, there's no visiting faculty running the track with the twins in Rwanda. The Rwandan faculty are coping with casual contact with me to support on a few specific issues. And I'm proud to have been part of the HRH project for nursing in Rwanda, and I can see the project is sustained. Thank you, Murakotse.
Thank you, Dr. Bengu, for an amazing presentation. Your work has brought you to Rwanda, but also the students of yours are sharing their knowledge that you have helped them to develop throughout the world. Thank you again. Next, I'd like to introduce Dr. Lakshmi Rajeswaran. She is an NYU Myers nurse educator and visiting faculty in the nephrology nursing track at the University of Rwanda School of Nursing. She has more than 30 years of experience in nursing clinical practice and teaching. Lakshmi has worked as a clinical nurse in India, Kenya, Egypt, and New Zealand, and has taught both undergrad and postgraduate nursing students for more than 15 years. She is also, again, she has published extensively, and she has also been at the University of Botswana for the past 15 years. She's a member of Sigma Theta Tau International, the Transcultural Nursing Society, and the International Council of Nurses. Welcome, Dr. Lakshmi.
Good morning, good afternoon, and good evening to everyone. Thank you, Robin, for your kind introduction. And my presentation is going to be highlighting the experiences and the changes what has been made by our nephrology graduates to improve the healthcare system in Rwanda. So the nephrology nursing is still a new area of specialty in Rwanda, and renal replacement therapy is offered in selected referral hospitals and in one private hospital. Currently, renal replacement therapy, that is the hemodialysis and peritoneal dialysis, is offered in 4 referral hospitals and in one private facility. And for renal transplant, usually the patients had to travel to India, France, or Belgium. So for clinical learning and practicum, these referral hospitals are utilized, and one private facility, the students, they go for their observation, which are located in the capital city of Kigali. The bed strength of each facility ranges from 6 to 8, and initially 2 HRH faculties were deployed by the NYU to teach the master's graduate students until 2019, and my other colleague, she left for a higher studies to South Africa. Currently, 14 master's prepared nephrology graduates are functioning as nurse leaders, and some of them are working in academic setting as well. Next slide, please. So how they are adapted into the system, 4 of the master's prepared graduates are working as assistant lecturers at the University of Rwanda School of Nursing and Midwifery. They are involved extensively in teaching undergraduate and master's students along with the visiting faculties. And they also function as a track leaders in coordinating different teaching and learning activities. And they also co-supervise the master students in the research process. And among the 4 assistant lecturers, recently 2 had gone for PhD. In the area of clinical practice, 9 of the nephrology graduates are functioning as nurse leaders in dialysis units at the referral hospital. And 1 nurse has left the country for a greener pasture. And all the dialysis units are located in teaching referral hospitals. 1 private clinic offers dialysis for affordable private patients. Next slide, please. These are the beautiful view of 2 referral hospitals located in the city of Kigali in a different location. And you can see these hospitals are surrounded by beautiful green hills. Next slide, please. And now what they are doing in relation to teaching and mentorship. They continue the teaching and mentorship, mentoring the colleagues, especially doctors and nurses. And when they teach concepts related to hemodialysis, patients' care during and after dialysis are taught to the doctors and other healthcare professionals. They also provide on-the-job training for the novice nurses in the dialysis unit, and with the specific focus on renal replacement therapy concepts. And they teach about teamwork, communication, and able to transfer the knowledge and skills what has been gained in the master's program. And the regular in-service education has been continued to the nurses working in the unit on peritoneal dialysis, and different topics are based on the needs identified in the unit. Next slide, please. The teaching does not stop with the nurses alone. They educate the patients regarding chronic kidney diseases, fluid management, nutrition, process of dialysis, and the renal transplantation. And they involve the family members during their teaching process, since family care gives the main part of the caring process. So they involve whoever is available during the teaching session. And involving the fellow patients as a peer educators is also taking place on regular basis regarding the long-term management of dialysis. This helps the other patients to be confident, and they get motivated to continue with the dialysis. Here I highlighted the verbatim from the nurse leaders from Rwanda Military Hospital and Shiashika Referral Hospital. The nurse leader from Rwanda Military Hospital said that we observed in India how the team worked on its punctuality and the communications that help to provide the quality care. I am able to transfer the knowledge in my settings. And Marie-Louise told that I am able to teach regarding nutrition to patients since I learned the nutritional management during my internship in Kenya. Next slide, please. And they are able to make the changes in the healthcare system. The first one is the quality of care is improved, specific to the hemodialysis patients. They increase the blood flow by assessing the patient's weight and the other access. And also the ultrafiltration rate has been adjusted, depends on the weight gain and weight loss for the patients. And also they drain the fluid in the bloodlines. These are very, very important concepts to adapt in the practice setting to maintain the dialysis adequacy. And infection control has been given a prime importance. Our graduates are able to teach the proper hand washing techniques to the fellow nurses and to the other colleagues. And they use the separate sets for sharing and closing the hemodialysis. And a separate machine has been allocated by advocacy for infectious and non-infectious patients. This helps to prevent HIV/AIDS and also hepatitis B, sometimes MRSA among patients. And I can say proudly that they increased the number of shifts of dialysis in the 2 referral hospitals. Instead of doing 2 shifts, they also did the 3 shifts. And one of the nurse in the military hospital, she advocated in allocating the resident doctors specifically devoted for the dialysis unit. The verbatim from the Shiashika nurse leader, I was able to make changes in improving the quality of the hemodialysis due to the experience gained in India during our internship. Next slide, please. Interprofessional collaboration is also an ongoing process happening on day-to-day basis. Our graduates are able to develop interprofessional collaboration with the psychologist, nutritionist, social workers, and biomedical engineers and nephrologists in providing effective renal dialysis. They involve other healthcare professionals in patients' care, and they also provide suggestion to the doctors in managing the patients. Verbatim from the Rwanda military hospital, I am able to convince the doctors with my knowledge and skills in nephrology in managing the patients. We are respected and recognized because of our specialization. The nurse leader from Shiashika said, doctors listen to our suggestions in managing the patients. This is because of our master's degree. Next slide, please. They are also able to develop some policies in regarding to hemodialysis. Informed consent has been developed, and also policies regarding the starting and closing of hemodialysis have been developed and waiting for the approval from the Quality Improvement Committee. Next slides. 4 of our nephrology students were able to publish in peer-reviewed journals, and some manuscripts have been accepted and waiting for publication, and 2 of them are functioning as a principal investigator and conducting research related to hemodialysis. Here, I would like to express my sincere thanks and support offered by Dr. Jaldin Sironda, who was my former colleague. Next slide, please. Community outreach has been a part of our development, and they collaborated with the Rwanda Kidney Association and conducted community outreach before the COVID-19 pandemic. And the first cohort of students, they conducted a community project in a local industry, and they were able to screen 300 employees for non-communicable diseases. And second cohort of students, they also gave a health education on Ebola during the outbreak of Ebola in DRC. And they also gave in the private bank, and they developed a proposal to conduct an outreach program on kidney nutrition. Next slide, please. Renal transplantation is a great development which is going to take place in Rwanda. The government of Rwanda is planning to embark on renal transplantation facility in Kigali from early next year. Planning is going on, and I can say proudly that one of our master students prepared in nephrology nursing may participate in the transplant program. Next slide, please. And impact on the healthcare system, they are able to improve the quality of care and infection control, and this helps them to provide cost-saving nursing care, and they are able to educate the family, patient, and community with a special focus on preventive nephrology, interprofessional collaboration, and increasing the number of dialysis, and they have rendered dialysis services even during the pandemic without any interruption. Next slide. Achievements, 2 cohorts of students, they went to India and Kenya for their internship. This allowed them to achieve some proficiency in specific techniques related to hemodialysis. They observed renal transplantation and renal biopsy. They also appreciated how the interprofessional collaboration, teamwork functions efficiently in the different settings. Challenges, it was a challenge to get the license in Nursing Council of Kenya, but it has been solved within a week. And the students, those who went to India, they had an initial setback in acclimatizing to the new work environment, language, and food and weather in India, but they got used to that. Next slide, please. Lessons learned. We learned that bridging the theory practice gap by international collaboration is very, very important in running any academic program, and understanding the context of country's educational system and students from the social and cultural perspectives in a non-judgmental way, and interprofessional and multi-sectoral collaborations with the public and private stakeholders are also vital, and utilizing the available resources to enhance the teaching and learning of the students, and cultural acceptance and accommodation and preservation. It was observed by our students, those who went to India. And resilience, hope, and acceptance, especially during pandemic, all the students showed a great resilience and they accepted the situation and they, you were used to the online teaching and they achieved their goals in the learning process. Next slide, please. Future developments, Alumni Association has been already formulated and scope of practice is going to be soon implemented, and we encourage all our graduates to get a membership in some of the international organizations, and also they strengthen the collaboration to the public and private stakeholders. Next slide, please. Pre-workshop for the students before they travel to different countries is very, very important, and plan for international collaboration for high-income countries to middle and low-income countries are also very vital to improve the collaboration between the many countries. Next slide, please. These are some of the photos which has been showing in a peer education. Our student, he was trying to insert an AV fistula needle and has been observed by his colleagues in India. Next slide. And this was a group photo. Some of our Rwandan students did a presentation on the healthcare system of Rwanda. Next one. And this is a clinical setting in India where more than 70 patients are dialyzed per shift. And our students are participating in the learning program. Next slide. Cultural exchange was taking place. Our Rwandan colleague, she was giving a token of appreciation to the Principal College of Nursing. This is a peace basket, which is a great symbol of Rwanda. Next slide, please. This was taken in Kenya when the second cohort of students were going for an internship. Next, please. The students are getting ready to participate in the transplant program. The next one, please. This is a community project where the nephrology graduates were managed to screen more than 300 to 400 employees of that particular local industry. Next one. We involve the undergraduate students during our community project. Next slide, please. And two of our students managed to present the research work in the regional conference, which has happened in Kenya. Next one. Recently, we formulated an alumni association. They are the future leaders of nephrology nursing who are determined to take the nephrology nursing to the higher level in Rwanda. You can see all bright faces in this photo. Next slide, please. Here, I would like to acknowledge my sincere thanks to Ministry of Health of Rwanda and the Human Resources for Health program and University of Rwanda for sponsoring the internship program for our students, and also nephrology graduates who were willing to share their achievements with me, and the host countries, St. John's Academic Teaching Hospital and Kenyatta National Hospital, Nairobi, Kenya. Thank you for listening, and I would like to welcome questions at the end of the session. Thank you.
Dr. Lakshmi, thank you very much for your insightful presentation. At this point, we've already heard about the expansion of the critical care master's program in Rwanda and the expansion of the nephrology master's program in Rwanda. So we're looking forward to people entering their questions in the Q&A chat box so that we can continue this conversation after all of our panelists have presented. And on that note, I am enjoyed to present Dr. Ruth Sego, who is a former NYU Myers nurse educator and visiting faculty with the Oncology Master's track at the University of Rwanda School of Nursing and Midwifery. Prior to her work with Myers, Ms. Sego worked for 7 years as a clinical oncology nurse at the Moi Teaching and Referral Hospital in Kenya, and for 1.5 years as a lecturer at the University of Kabanga in Kenya. She is currently in her final year as a PhD student at the University of KwaZulu-Natal in South Africa. Her thesis research is analyzing existing cervical cancer policies in relation to implementation, gap identification, and barriers to cervical cancer screening, and finally developing a cervical cancer health promotion package for local women. Upon graduation, she plans to join the Aga Khan University Teaching Hospital in Kenya to continue her oncology nursing educator role. Welcome, Ruth Sego.
Thank you, Professor Clark, for your introduction, and greetings to all the viewers. Welcome. I'll take you through the oncology nursing program Oncology care is a highly specialized division of nursing, which requires a higher level of training and education following a basic preparation. And therefore, the country of Rwanda, which is one of the developing countries, initiated the education of oncology nurse specialists in the year 2015 at the master's level. So this was really huge and good news to the entire East African community because very few had initiated this, and most of the people used to go abroad to seek oncology education. So this is a 2-year program, and a twinning with the local faculty was integrated, and this was really helpful in terms of planning and identification of the clinical sites and even like culturalization. So I really applaud the University of Rwanda for integrating the twinning system. So this was implemented in a modular system with a total of 14 modules. And the focus of the curriculum was basically on the screening, diagnosis, treatment, management of related treatment side effects, palliative care, end-of-life care, and rehabilitation. So the program so far has had 2 successful cohorts. The first cohort had a total of 10 students who graduated successfully, and the second cohort had 9 students. Also, all of them graduated successfully. What is on session now, and they are graduating very soon. Next slide, please. So various clinical sites were identified with the help of the twinning program. And the first one was the University Teaching Hospital. And this hospital is really within the Kigali city. And the focus is on screening services. They offered, they had a well-established mammogram, ultrasound, and even cervical cancer screening. They also did surgical interventions, particularly for diagnosis purposes, biopsies, and even treatment purposes. So this was really a good start for our students in their clinical site. The second one is the King Faisal Hospital, which is a private, and they offered screening services, diagnosis services, surgical, and medical oncology. This was also really good for our students, and it is within the Kigali city. Then the next, the military hospital, which is a government facility within Kigali also, offering surgical oncology. And about 2 years ago, they started offering radiation therapy. And this was really huge because initially we were very worried graduating our students without having an exposure to radiation oncology. So this was really huge. And again, it was good news to not only to Rwanda, but to the entire East African community, because we were seeing already patients flocking in from Congo, Uganda, and even other countries nearby. So this was really good news to the entire community. Then the next hospital was Butaro Cancer Center of Excellence. This was really the hospital we were going to use for our chemotherapeutics exposure to the students. And this hospital was collaborating, or is still collaborating with the Partners in Health, who later really offered support. And it is the only hospital that we chose, which was really far in the northern province of the country. And it is about 4 hours drive away. So they basically did screening, surgery, and medical oncology services. Then we had a palliative care hospice called Kabuga within the Kigali city, and Rwanda Palliative Care and Hospice Organization, which is a non-governmental organization offering voluntary palliative care services. So this basically really exposed our students whereby they did home visits to take care of terminally ill patients, particularly taking care of their pain and other symptoms which arise. Next slide, please. So after designing or identifying the clinical sites beautifully, something was missing, and that is personal protective equipment. And as you know, oncologists cannot function without personal protective equipment because of the nature of the drugs that we do handle. So we had really serious consultative meetings about this. So we thought, should we really shut down the program? We said, no, we have to pursue other means. So we had discussions around having the students pay for the PPE, but I thought that was really too much for the students because they were already struggling with the fees. So I remember talking to the Dean Donatilla. She was really supportive on this. We had meetings, serious meetings on this, and we decided to approach PRH. We had somehow interacted with them and asked them if they could accept to support students in provision of PPE, and really they did. I'm really indebted to that. They accepted, and so one problem was off the shoulder, and yeah, so and again we needed a long-term approach to this because PRH was this kind of support for a long time. So we raised the need of procuring PPE by the university, and so we did a list and their prices and where to buy because they were not available locally, and this was channeled to the procurement department of the university. And as you know, some of the institutional procurements can really take long, and I hope this was fixed. Next slide, please. So I'm going to focus about the Butaro Cancer Center of Excellence, which I had mentioned is 4 hours drive away from Kigali. They specifically do chemotherapy and cancer surgery. So initially, before we went to this hospital, I had really thought about having the students go abroad for internship, but unfortunately, a funder did not come through. So, but when we got to this hospital, I was so surprised. It is a replica of a state of oncology, and nothing to miss because we didn't get the chance to go abroad for internship. So they specifically do chemotherapy and cancer surgery. So they are well established. They got an electronic medical record with chemotherapy order entry, and they have a well-designated area for mixing chemotherapy with a biosafety cabinet. Safety in oncology is very important. So this particular hospital was really well structured. They had a cabinet for mixing chemotherapeutic agents. So I was so happy our students were safe. And they had a radiotherapy referral program, that is before the military hospital started, whereby they even paid for patients requiring radiotherapy to Kenya or even to Uganda. So that was really a good exposure to our students. So they also got an ambulatory cancer center whereby they offer daycare treatments, specifically chemotherapy for those patients who are ambulatory, in really a beautiful setting, which was really conducive for learning for our students. So they also have an inpatient adults and pediatric oncology units, which our students extensively benefited from, and we were able to achieve all our goals. This particular hospital also has a support center whereby, since it's really far, we have patients coming from all over the country. They have a housing for the patients who are staying in for long together with their family members. And in addition, they got a good support system whereby it is led by a psychologist to support patients psychologically, emotionally, and all the aspects arising. So our students were able to participate in all this, and they were able to learn a lot about supportive care in cancer care. Next slide, please. So the first is the Butaro Cancer Center of Excellence in collaboration with PRH. It is, as I had mentioned, it is a really beautiful place. You can see the green and very conducive for learning. So the second photo shows the inpatients, that is the female side, whereby patients who need who are experiencing side effects of chemotherapeutic agents, or those who are getting chemotherapy, long regimen chemotherapy, were admitted there. So our students were able to do a lot of chemos in a conducive environment. Next slide, please. So that is the first photo is the ambulatory center, whereby the daycare chemos are given. And on the other photo is one of my students giving chemotherapeutic agents, well prepared in a protective, personal protective equipment. And the other one was looking on. Next slide, please. So that is the beautiful outpatient chemotherapy unit that I was talking about. they're really well equipped with recliners where patients receive chemotherapy very comfortably. And that is one of my students in the ambulatory section who was giving chemotherapy. Next slide, please. So the first photo is the Rwanda Cancer Center, the military hospital, where they have a radiotherapy unit, and it is well equipped with 2 Linac machines. So that is really good news. And the second photo is during inauguration of the unit. It is now fully functional, and our students are really benefiting on that. Next slide, please. So these are my students from the first and the second cohort. The first photo is myself and the students from the first cohort. We were working down to agents. And the second photo is the students from the second cohort after class. We had just concluded the class. Next slide, please. So the first photo is during a conference, which was taking place in Kigali. That is the African Organization for Research and Training in Care. If you look at the photo, those who are in black are the students, and that is myself with my twin. And this conference was the first in the country, sorry. This was the first happening in Africa, and they had chosen Kigali. And so the registration fee was really high. And so we had to negotiate with the secretariat. So they allowed our students. I'm really sorry. They allowed our students to participate. So they had to observe protocol in terms of passing around the microphones and showing directions, assisting the visitors. And we had so many papers to present that day. So it was a win-win situation whereby the aortic conference benefited and our students also benefited. On the second photo is the Multinational Association of Supportive Care in Cancer. It was taking place in Austria, Vienna, and I was able to attend with one of the faculty members who happened to have been one of my students in the first cohort. And we had a paper to present. We were able to network with many dignitaries, and we learned a lot. Next slide, please. So community outreach was one of the goals which were required by the university to be achieved. And so we were able to conduct many, and it was student initiated. So when we went to the cancer hospital, we noted that most of the breast cancer patients came from a particular community. And so the students chose that we do a community outreach from there. If you look at the band, it is specifically done in Rwanda, and it was for focusing particularly on breast cancer. And so we had a successful day during a very busy market day. Next slide, please. So after graduating these students, they were deployed to various hospitals. Some went back to where they were working on promotion, and a majority of them remained at the University of Rwanda to continue as faculty at the Master's Oncology track and undergraduate program. Others went back to the various hospitals, and I'm happy to say that one of the students from the first cohort was promoted to nurse educator role at the Butaro Cancer Center of Excellence. Another one was promoted to take charge oncology and radiation units at the military hospital. And 2 of them from the second cohort are working at the King Faisal Oncology unit. Merci, merci, thank you very much.
Thank you, Ruth, very much for your presentation. Ruth was the original architect of the Masters in Oncology Care, but our next and final panelist is Dr. Margaret Fitch. And Margaret Fitch is an NYU Myers nurse educator and visiting faculty with the Oncology Masters of Nursing track at the University of Rwanda School of Nursing. She's also an adjunct professor at the Bloomberg Faculty of Nursing at the University of Toronto and works as an independent consultant in research and education. Dr. Fitch has a long career in oncology as a clinical nurse specialist, researcher, and head of department at the Odette Cancer Center in Toronto, which is one of the largest centers in Canada. In addition, Dr. Fitch founded the Canadian Association of Nurses in Oncology and served as the president of the International Society of Nurses in Cancer Care. She is currently the editor-in-chief of the Canadian Oncology Nursing Journal, and throughout her career, Dr. Fitch has had the opportunity to work with colleagues on palliative care and cancer nursing in more than a dozen countries across North, Central, and South America, Europe, Australia, Asia, the Middle East, and Africa. Thank you, Dr. Fitch.
Thank you, Robin, for that introduction. And I appreciate the opportunity to say a few words about the continuing growth and capacity building within Rwanda's oncology nursing program. In the
Dr. Fitch, I'm going to interrupt for 1 second. My apologies. So to our attendees, we are going to go over 15 minutes. We hope that you can remain on the webinar and join us for a potential question and answer afterward. But we want to make sure that we give full time to all of our presenters and time for Q&A after. Sorry for the interruption, Marge.
No problem. I appreciate everyone staying in terms of the end of this presentation. I'm looking forward to the Q&A. I wanted to start by saying that my involvement in the program was really a testament to the importance of networking. I had met Ruth originally in 2010 when I had taken a team of oncology nurses from the Odette Cancer Center to Eldoret in Kenya, where she was working at the time. And she participated in the workshop. We kept in touch over the years, and then she invited me to the University of Kigali in 2018. Next slide, please. My opportunity at that point was to be exposed to the second cohort. And the whole experience was one in my own flexibility. Entering a program that's already established, you're there as a guest lecturer, the idea of questioning yourself and always being sure that you recognize you may have knowledge, but the application of that knowledge and how it's going to work in another country has to be with the expertise of the colleagues in that particular country. This was also an opportunity to be exposed to the curriculum and exposed to the desire on the part of our Rwandan colleagues for a PhD prepared individual to work with the program. Next slide, please. There were 3 insights that I wanted to share with you very quickly, and I think these are so important for any visiting faculty, but particularly when you're moving into in-country and working with a program that's already established. First, living in country is very different from being a guest who only drops in for a week and a half. There are many things to learn, and it takes energy actually to make sure you're learning the appropriate kinds of things. Practicing cultural humility, recognizing that you have your own assumptions, your own way of doing things, but that doesn't make it always right. One needs to understand there are other ways of doing things and works collaboratively with your colleagues to make sure that happens. And finding your own place, finding a niche where you can make a contribution based on your expertise, but that contribution is one that matches the needs that have been identified by the colleagues in the local setting. Next slide, please. I worked with a 3rd cohort, and we were teaching in the classroom at that point in time. But the emphasis that I was trying to work with was the idea of enhancing evidence-based practice, knowledge, and skills, the idea of being a change agent and introducing innovation within a clinical setting, and being a leader, a clinical leader in terms of advanced practice. And in terms of working with the faculty, our focus was really on teamwork. The idea of sharing a vision of what the graduates will be and how they will perform, and including members from the local environment, local facilities, and the expertise of the clinical wealth of knowledge that they might have at the time. So having team planning, team coordination was where we were trying to build the capacity at that point in time. Next slide, please. In terms of the clinical, I actually had to move back to Canada because of COVID. So the clinical was not part of my own personal experience on site. But what we were trying to work on was the idea of having very clear objectives for the clinical placement, for the students, for the preceptors, the staff members who might be helping the students, and also making sure that the students understand what their expectations actually were going to be. And the clinical was delayed because of COVID, but eventually they were able to move through that. And you can see the picture in the center, how happy they were to be in the clinical environment. Next slide, please. In terms of the contributions at that point in time, I did find my niche, and that was really in building the capacity around research, writing, and publications. We were able to work both the faculty as well as the students. And I'm delighted to say we had workshops on redesign, on writing, on publication. We had 2 students who have successfully published peer-reviewed publications. One student has presented at an international conference, and these are beyond the ones that Ruth actually talked about. We've had 2 faculty peer-reviewed publications and one more just accepted yesterday in global oncology. We were able to start 2 other projects that are still underway. One faculty is here in Toronto, the University of Toronto, doing her PhD, and one faculty member is enrolled in PhD work in Rwanda. We were also able to begin talking about building an association or a community of practice for oncology nurses. Since my return, if I could have the next slide, I have been working remotely. And this is what I see when I teach at 3 a.m. in the morning to accommodate the time differences. And next slide, please. There are no doubt challenges. It's not entirely as satisfying as being in person and interacting with the students directly. The students actually experience internet connectivity problem, electrical outages that happen unexpectedly, and of course, no one can control those. But they have less interaction with the fellow students as well as additional costs. For me, I find it much easier when students are on their own computers and we can interact that way. The hybrid of having some people in class and some people on their own computers is not quite as helpful. I miss the nonverbal communication, the observations that I can make. And I worry about the language when I don't have those nonverbal communications and can't quite see when people might be looking a little lost or a little confused. I do joke at times that it's a little like working a night shift, which takes me back many years, but I've always loved night shifts. And so I've quite enjoyed doing the online work because it allows me to remain connected with the program. Next slide, please. In terms of just drawing my remarks to a close, I found there was an incredible eagerness to learn and to grow on the part of the faculty, on the part of the students, and creativity in terms of working with limited resources. But I can't emphasize enough the need to have bidirectional learning. This is so important that we're learning from one another and recognize that I might have a role to share knowledge, but the local adaptation is so essential. In terms of online work, it can work, especially for the theoretical perspectives of the content. It doesn't work as well in terms of the clinical, but I think there are innovations that could well be added in terms of case discussion and so forth. So on that note, I will draw my remarks to a close. And if I could just have the last slide, I want to say thank you. This has been an incredible opportunity personally, and a huge vote of thanks to my colleagues in Rwanda and to my colleagues at NYU. You've all made it possible. Thank you.
Thank you, Dr. Fitch, for wrapping up this amazing second Dean's Global Lecture Series for all of us For those of you who have been able to stay on the webinar, thank you for staying. We have noticed that there are no questions in the Q&A box, and I am anticipating that that is because everyone was listening so intently to all of the presentations by our esteemed panelists. So because there are no questions in the Q&A box, I have posted a question to all of our panelists in the chat for them. And the question is this: from your perspective, what is the priority issue to ensure sustainability of advancing nursing and midwifery education and practice in Rwanda? And Dr. Bengu, will start with you. Very short 1-minute explanation.
I have already observed sustainability in my track because I have left while there was someone who came and went. The faculty that I left, that is Liberata, she is holding the fort and she's going on and she's introducing new things. Secondly, to sustain, the Nursing Council must get involved through registration, which is very important for recognition of these people who can then be utilized by the country. Thank you.
Thank you, Dr. Bengu. Dr. Rajeswaran.
Thank you, Robin. I think like Busi mentioned that we need to, train more Rwandan faculties for sustainability, because 2 of them have already gone for PhD, and I'm remaining with one Rwandan faculty who is also aspiring to go for PhD soon. So on that aspect, probably nobody will be there to do nephrology nursing soon. So we need to mentor more faculties and train them to be in the country after the PhD and encourage them to come back. And also the scope of practice, which is going to be accepted soon, but it has to be done very early so that whoever is planning to come for the nephrology nursing, they wanted to know what is the scope after they finish the master's program. So those areas should be clearly depicted, and if they implement the support of Nursing and Midwifery Council and University of Rwanda, probably we will have more nurses enrolling into the program. We need more graduates to come into the program.
Thank you. Ruth, comments, ideas?
Yeah, thank you, Professor. I would say that mentorship is very important in sustaining and smooth transitioning, because you see faculty at some point, visiting faculty at some point will leave. So mentoring the junior staff and allowing them to go back to study so that they can be prepared enough to take over. And secondly, I would say that networking is very important because we have all over the globe who can deliver even remotely, like what Professor Fitch is doing now. So networking and making friends around is very important for sustainability. Thank you very much.
Thank you. And finally, Dr. Fitch.
Yes, I would say my colleagues have identified some key priorities. I'm not sure that I can add much more, other than I do think there's something to be said for, I'll call it marketing, actually communicating what specialty practice nurses can do, and having the language and the ability to share that with politicians, share that with decision makers, and really be very clear how having specialist nurses can improve the quality of healthcare.
Thank you, Dr. Fitch. And it's an amazing segue to wrap up this webinar and to address one of the questions that was posed regarding the continuation of visiting faculty with the HRH program. Everything is a moving target. So many programs, so many initiatives depend on, as you have identified, Mark, the economies of a country, the politics of the country, the ministries within the country. And we are very excited that the president of Rwanda has appreciated and understood that the economy will gain speed and move forward in any country when its citizens are healthy. And to have healthy citizens, we need clinicians that are prepared at the highest level possible. And in that realm, the country of Rwanda has put forward the health professionals' continued capacity building for 2020 to 2030. So this is a very exciting initiative that is moving forward, and the plan is already in place. It's already been activated on multiple levels. So if folks in Rwanda and some of our Rwandan colleagues who are on the webinar right now can look up that particular initiative. If Carrie can help me, maybe she can find it online and give us a link. But it's critical. And we've been in conversation with the HRH Secretariat, Mr. Joseph Shema in particular, and we are working forward on it. So this project is long, it's deep, and it will continue to move forward, not only for the citizens of Rwanda, but as we've heard from all of our panelists today, for the citizens of Central Africa, East Africa, and beyond. So thank you all for your attention and your attendance today. And I'm enormously proud to be a colleague of all of the panelists that were here today. Thank you so very much.